the College of Anaesthetists, we are striving to involve patients more in the decisions made about their surgical care. Nearly 3 million patients undergo surgery in Australia and New Zealand each year, and although surgery is safe, we believe there is huge potential to make the system work better, particularly for the group of nearly 400,000 patients at high risk of complications who account for more than 4 out of every 5 deaths after surgery. These patients typically have other medical conditions such as lung disease, diabetes, or heart disease. Here's an example. Meet Doug. He's just been diagnosed with bowel cancer, and his surgeon has told him he needs a major operation to remove the tumour. Doug's GP has also been treating him for lung disease caused by his smoking and is aware of problems with his kidney function, but this is not making Doug feel unwell. Since his wife died, Doug lives alone. He has a son, Adam, and a daughter who lives interstate. Doug has spent the last few years saving for a trip to visit his daughter and her young family, who he has never met. Despite the lung and kidney issues, it is thought that surgery is Doug's best option for cure. Like the majority of operations, it is a technical success and the tumour is removed. But a few days after surgery, Doug's weakened lung function deteriorates and he develops pneumonia, so Doug is admitted to a critical care unit for more intensive treatment. Although he receives the best care, Doug's lung and kidney function worsen and he is sedated while he receives ongoing treatment. So, despite successful surgery for cancer, Doug is actually much less healthy than before. Whilst he is sedated, Doug is unable to communicate, and so his care team decide on the types of treatment that are suitable and turn to his son Adam to help them decide which course to take. Unfortunately, Adam is unsure because they never had any discussions about Doug's values and preferences. Because of this, the care team make what they believe is the best decision for Doug and start him on dialysis therapy for his kidney failure. This means that Doug needs to stay in hospital many months longer than expected before he's ready to go home. After returning home, he continues to come into hospital for ongoing dialysis treatment 3 times a week. Although he returns home, Doug is much weaker than before and is no longer able to manage at home by himself. He moves into a nursing home and slowly improves, though never to the level of function he had before the surgery. He also spends much of his time travelling back and forth to hospital for his dialysis treatment, and this significantly limits the time he can spend on activities he previously enjoyed. Dialysis also means that Doug is now unable to make the trip to visit his daughter, a long-held wish since his wife died. When we zoom out and look at this pathway and see Doug's eventual outcome, we can see it is very complicated and involves lots of decisions about what type of care Doug receives. However, Doug has very little input into the decisions that affect his health and future quality of life. Let's compare this to another pathway for Doug, where we take a more shared approach to choosing his treatment. This time, Doug is referred to a perioperative medicine team as soon as the surgery is considered, and one of the doctors on the team, in this case an anaesthetist, identifies Doug as being at high risk of complications. For a period of time before surgery, the team works with him to improve his medical conditions and fitness, a process called prehabilitation. During this time, the team, which also includes a surgeon, an intensive care physician, and a kidney physician, meet up to discuss what types of treatment choices are available to Doug and the risks associated with each treatment. They also discuss with Doug what his goals are for treatment and the future. This helps them make a recommendation to him about which treatment pathway will be most likely to help him achieve these goals. This whole process of enabling Doug to make informed choices about his treatments is called shared decision-making. Together, the perioperative team and Doug decide that going ahead with surgery is what is best for him. However, based on the recommendation by the team, Doug decides to have a less complex surgery that will not cure him of cancer, but instead aims to control his symptoms for as long as possible. Doug also nominates his son Adam to be his medical treatment decision-maker in the event he cannot make decisions for himself. He discusses with Adam the things that he values, including being able to remain independent and to stay at home as long as possible. They also discuss what Doug's preferences would be if he had complications after surgery and became seriously ill. Together, they document these values in an advance care plan. Now, after Doug goes in for his surgery, although he still develops some complications and becomes ill, he avoids getting kidney failure that requires dialysis. This time, because Doug has an advance care plan, Adam is able to effectively advise the perioperative team about what Doug would want taken into account when medical decisions are being made on his behalf. All this means that although Doug has not been cured of cancer, he gets to go home quicker and remains independent at home. Importantly, he is still healthy enough to make the trip to visit his daughter and her family. He also decides that in the event that his health deteriorates further, his priority would be receiving care that focuses on relieving pain and discomfort. It is clear that this pathway allows Doug to be much more involved with the decision-making process and acknowledges that the medical decisions being made about his care are about more than just medicine. It also takes into consideration that patients in the same situation may choose different treatments depending on their personal circumstances and what risks they are prepared to take. Most patients are at low risk of complications and won't need a major change to their pathway of care. But for the growing number of high-risk patients, we believe that shared decision-making will help them make informed choices and, by doing so, give them personalized care better suited to their needs. This thinking has already been put into practice in some hospitals in Australia and New Zealand, but we want to work to make it a part of normal care for all patients. Your doctor or other healthcare worker may discuss shared decision-making or an advanced care plan with you. We also invite you to ask them for more information. We hope that these types of discussions will help us provide the care that is best for you. Thanks for watching.